Afternoon, everyone, and welcome to our regular UCT COVID-19 ECHO webinars. On behalf of myself, Wendy Spearman, and my co-host, Mark Sondra, we really welcome you to our weekly meeting, and we once again thank Project ECHO of University of New Mexico for allowing us to use our viral hepatitis license to run these webinars. Today, Graham Menkes will be introducing our speakers, and our main speaker today is Barry Bloom. Over to you, Graham.
Thanks, Wendy, and welcome to everyone to our ECHO webinar, COVID-19 webinar hosted by the Department of Medicine at UCT. We're going to start off this afternoon with our regular update on the COVID-19 epidemic, both in the Western Cape and some issues around South Africa more generally, from Marianne Davies. Marianne from the UCT School of Public Health and the Western Cape Department of Health. So over to you, Marianne. Thank you.
Thanks very much. Just to say that it's always a privilege to be to give these talks and to share a platform with the second speaker, but in particular a privilege to share a platform and be the curtain raiser to really a guru of public health, Professor Bloom, today. So this is the graph that I think many of you have become familiar with, that we show at each of these talks, which tries to summarize. Sorry, we go to the previous slide, tries to summarize in one place the cases in grey at the back, current admissions in blue, deaths in red, and proportion positive in yellow, and right at the top, the oxygen use in the province, with the dotted lines showing estimates for hospitalization, for COVID hospitalizations and deaths respectively. We've stopped trying to estimate COVID hospitalizations because we think testing in hospitals is now much more widespread, and it's unlikely that we're underdiagnosing COVID in PUIs. And I've just put a dashed line to show where we were 3 weeks ago, and you can see that pretty much those numbers have remained relatively stable over the last 3 weeks, although if you look closely, there's certainly a hint of an increase in the hospitalizations and similarly in the oxygen use. But it's difficult to see those small changes because everything gets swamped by where we were before. And so while I think it's important to see where we were before, to put where we are now in perspective, if we go to the next slide, we're going to focus in just on the period since the beginning of September. So it's a busy slide, and I'm going to start on the top left and go clockwise. Here we're looking at new cases per day, those diagnosed in the public sector in yellow and in the private sector in blue, starting on the 1st of September. And then we've added to that a 7-day moving average, which is in the darker blue color, and in turquoise, a 14-day moving average. And you can see that the 14-day moving average sort of smooths out some of the bumps and gives us more of a sense of a trend. So on the 1st of October, we hit our provincial low of a 7-day moving average of 115 cases per day, and we're all feeling in a marvelous mood. That low was artificially low for two reasons. The first is there happened to be a public holiday in the 7 days before that, which reduced testing, and it was effectively a long weekend, so 4 days of almost no testing. And the second is that we weren't yet testing all symptomatics. And literally 2 days later, we had the super spreading event in the southern suburbs, or potential super spreading event in the southern suburbs, followed by a steep increase in the number of cases. And we were informed that the province was officially in resurgence. 2 weeks ago, we got to a peak of the 7-day moving average of 233 cases per day. And then last week, everything was looking pretty rosy. But in fact, this week we're back at 236 new cases per day on average. So not major increases since the what was termed a resurgence, but certainly not seeing anything in the way of a decrease. On the right-hand side is the testing, and you can see certainly an increase in testing numbers once we started testing all symptomatics. Initially predominantly in the private sector, but actually also a small increase in public sector. We're doing about 20,000 tests per week, And in public, we're doing about 87% of the tests that are being done in private. So just less than half of the tests are being done in the public sector. And then the bottom right is the proportion positive, which if you look at this, we've got public and private tests, but the 7-day moving average is really for both of them, but in fact is very similar. There's been a sort of slight increase since late September, but we're still hovering below 10%. And then what's interesting is when we see these increases in transmission, they kind of reflect everywhere. So on the bottom left, we have seen an increase in healthcare worker infections, and also for the first time in a long time in the metro, we've started to see some cases in long-term care facilities. You can go to the next slide. This is just taking a closer look at the hospitalizations, public sector on the left and private sector on the right-hand side, and you can see the small increase in hospitalizations in both public and private. And we have confirmed with the private sector that there's been no change in terms of testing policy, and that this is genuinely an increase in admissions of patients who are sick with COVID-19. And that's also reflected by the fact that the ICU admissions have gone up in parallel. Go to the next slide. Of course, we're not in isolation, and I'm sure everyone's been reading the news. So these graphs are taken off the Bekisisa website and show the daily new cases by province. And they don't have, you'll see there's no numbers on the vertical axis because they're just showing the relative changes. And so the absolute numbers might be quite different between the different provinces. But what you can see is a downward pattern in all provinces except the Western Cape, which is looking flat. KwaZulu-Natal is a little bit less downward than the rest, and then the Eastern Cape, which is heading upwards. And on the bottom is the cumulative hospitalizations since the start of the epidemic for those hospitals that report to DATCOV. So, of course, this is very much influenced by the fact that not all hospitals report to DATCOV and that that's changed over time. But what you can see sticking out quite clearly is the increase in hospitalizations in the Eastern Cape, which is the green line, and there's a small increase in the Western Cape as well recently. And I don't think there's been a big change in reporting to DATCOV in recent weeks. We can go to the next slide. And then we've had an actuary who's written some very nice code to calculate the reproductive number based on cases throughout the epidemic. We haven't been showing this. This is for the Western Cape. I think for a long time we didn't really want to rely too much on the reproductive number based on cases because of the limited testing capacity, particularly at the peak. So I think some of the drop that we see during the month of June and July might be due to limited testing, but we can certainly see very low levels as we reach September, and the uptick that occurred during that period when we saw the increase in cases and now seems to have come down again, although I haven't actually seen the most recent data for this week, but is looking like it's in the below 1 stage. And certainly for many of the countries internationally in the Northern Hemisphere are basing policies on restrictions or when one needs to intervene based on the reproductive number. So it's something that we do need to watch closely. Go to the next slide. So where are we seeing the increases that we have seen in the last few weeks? And what these two graphs are showing is a slightly different metric, which is the number of active cases on the left-hand side for the province as a whole, and on the right-hand side just for the metro. And the active cases are useful because those are the people who are currently infectious and can then cause further infections, and also because they last for longer, that they tend to kind of smooth out too many ups and downs. And what's interesting when we looked at this retrospectively was that there was almost this camel-shaped double hump over the period of the peak, which I think at the time we perhaps didn't take as much notice of. But what's interesting is with the eye of faith, you could perhaps think that those humps coincided with a dropping of the level of restrictions, and that perhaps this hump that we've seen now is also related to moving down to level 1 restrictions. The timing is certainly would support that. And if we look in the right-hand graph at the metro as a whole, and I realize it's a busy graph and it's difficult to see, but you can see that for most sub-districts, you do see that double hump pattern. But the two where you don't really see it are Khayelitsha, which is in orange, and Klipfontein, which is the light blue. And those are both the areas that had our highest seroprevalence when we looked at antibodies, and also the areas that have had the most pervasive epidemic in terms of their mortality. So perhaps, and also probably areas where, at least in parts of those areas, it's likely that lockdown had the least impact, and that really any social distancing due to lockdown might have been much less effective than in other areas. You can go to the next slide. So this is, again, just focusing on the last few weeks, and a similar picture to what I showed before, but the middle graph is just focusing on the metro, and then broken down by sub-district. And what we can see if you look at the top right is that southern and western, where we had the large increases in cases in early October, are coming down quite nicely, but haven't come down to the end of September levels, and that the one area where we are still seeing increases is in Khayelitsha, but I highlight that the axes of these graphs are different so that we don't hide small changes, and that those absolute numbers in Khayelitsha are quite small. You can go to the next slide. And then here is really where we are still seeing quite substantial increases. So this is the picture for our non-metro areas, and although overall it doesn't look like it's increasing too steeply, if you look at the bottom left at the garden route, you can see that we've got quite a steep increase going on there, which has been for about the last 2 weeks. And if we go to the next slide, this is just broken down by the different sub-districts in garden route. And importantly, the George area is on the right-hand axis, whereas the rest are on the left-hand axis because the numbers are so different. You can see that the increase is in George, but also in Knysna and Bitu. And a large number of those cases are actually holiday makers, so local holiday makers who have traveled into those areas and become ill and tested in those areas. And I think this is important as we approach the holiday season, because it's something we may see quite frequently over the next few months, and also important as we think about an increasing epidemic in the Eastern Cape. Those are areas that are close to the Eastern Cape, and we know that we might know about provincial boundaries, but the virus obviously doesn't. Then if we go to the last slide, I think several weeks ago, I told you that one of the ways that we would be tracking the epidemic in the post-peak period was to look at wastewater surveillance. So these are results from the sampling of 10 wastewater treatment plants in the Cape Town Metro. On the left-hand side is a figure for the 19th of October, and the right-hand side is 2 weeks later on the 2nd of November. And the 19th of October coincided with our peak in the southern and western sub-districts, which was related to the cluster of people who had attended the bar. And you can see that the affluent treatment works, which drains those areas, was in dark blue, and that we see much lighter blue 2 weeks later. And importantly, if you look at the legend, the scale is actually different. So the light blue on the right-hand graph is actually a lot lighter than on the left-hand side, and you can see the actual RNA copies and the spike in Athlone coincident with the large number of cases in the southern suburbs. And the MRC has made this available on a dashboard, which will be going public on Monday the 16th of November, so next week, and they are sampling on a weekly basis, so results should be available every Thursday, and now expanded to all 24 wastewater treatment plants in Cape Town and also to the Breda Valley. Thanks very much.
Right. Thanks very much, Marianne, for that very granular update of the epidemic in the Western Cape. So we're going to move on to our main speaker this afternoon. It's a great pleasure and honor to introduce our main speaker, who's Professor Barry Bloom. He's the former Dean and Jacobson Research Professor of Public Health at the Harvard School of Public Health. He's recognized as a pioneer in the field of global health. He trained in immunology, and his laboratory made some of the fundamental discoveries in terms of the immune response to infection. He's made important contributions to infectious diseases, vaccines, and global health policy. His research has focused primarily on immunology and pathogenesis of leprosy and TB. And he's been involved with the WHO for more than 40 years and played a lead role in advising the WHO on TB, leprosy, malaria, and other tropical diseases. Barry's links to Africa and South Africa have primarily been through his advisory role to KRIF in Durban, to H3 Africa, and to SATVI at UCT. In 2020, he's been an advisor to national governments on COVID-19 and is a respected voice internationally on the pandemic. He's been particularly active in interacting with the media around COVID-19 to ensure the messages reaching the public are informed by science. So Barry, we're very privileged to have you on our webinar today, and are really looking forward to your talk, which is titled A Public Health Perspective on COVID-19 in 8 Maxims. And so we're going to hear Barry's talk, and that will be followed by a panel discussion. I'll introduce the panel after Barry's talk. So over to you. Thanks very much.
Thanks so much, Graham, and thank you for this wonderful opportunity to connect with so many friends in UCT in South Africa. Let me start with a disclaimer. I expect you will learn nothing that you don't already know, and I'm not sure why I've been invited to give this talk, but I take it as a terrific opportunity to put it in the perspective of what I've called 8 maxims of public health. And I'll be very interested if it stimulates some good thinking and questioning in the discussion. The first maxim is something that I wrote in Science a long time ago that I actually think is right, which is that all health research is global and all healthcare is local. And I want to acknowledge, under a circumstance where the Chinese are being beat up by the government in my country, to point out that what we learned initially scientifically about COVID that saved the world an enormous amount of time came from 2 papers published in the end of January, one in Lancet, one in New England Journal, by Chinese scientists. I take some pride, both of the heads of the labs, the China CDC, trained at Harvard, and the dean of the School of Medicine in Hong Kong, also trained at the Harvard School of Public Health. And I think our school fought hard in the epidemiologic modeling group to talk about bending the curve, and Imperial College predicted that if we didn't act locally and globally, there would be a tremendous number of deaths. And that has regrettably turned out to be true. And I think the first perception that I think is really profound, that is diluted out when the numbers get created. COVID-19 has created a revolution in scientific communication, with preprints, with collaboration between competitors that we've really never seen in any other circumstance previously. A second point I would make is I had the privilege in 2003 of being invited as Dean of the School of Public Health to review for the Ministry of Health in China what they did wrong in SARS. And it came in, our report came in 3 speeds. The public health science was terrible. There was no system to communicate across provinces within the public health system to tell people what was going on in one place in this world's largest country. And thirdly, there was no capacity to explain risks and have the public respond effectively. I have another webinar tonight into Wuhan, and I would be able to say that the public health science in China is, in terms of epidemiologic modeling, diagnosis, testing and molecular epidemiology as good as anywhere in the world. There was put in, after our review in 2003, an extremely sophisticated rapid public health communication system that was bypassed by Wuhan in the early days of the outbreaks in Wuhan, which is a tragedy that slowed everybody down in China and globally. And finally, whether one likes how it was done, the public was informed very effectively how they had to respond, and they did respond, which led to the downturn in the epidemic after the extreme lockdown in China. So China really did learn the lessons to a large extent. Clearly, COVID is highly local, and as Anne pointed out, Marianne has pointed out, the effective R0 varies over time in different places. And this is just a picture of New York City. 5 different parts of the city vary by 15% in seroprevalence. And the way the data were obtained, I think, is very clever. Serum samples are taken from every pregnant woman, a healthy population, but representative population of every part of the city. And clearly in our country, and I think almost everywhere else, COVID has revealed inequalities, inequities, and vulnerable populations that we really are going to have to come to learn how to deal with. This is a maxim from Bill Foege, many of you know, was the person as an EIS officer in Nigeria who developed the ring strategy for wiping out smallpox, a brilliant guy, former head of CDC, major advisor to the beginning of the Gates Foundation. Saving lives is important, but interrupting transmission is what makes things go away. And in the context of that, what has been really difficult for leadership, political leadership, academic but not scientific leadership, is what is to us most obvious. What you see is not what's there. People do not understand, and we didn't understand, even the NIH didn't understand, the implications of asymptomatic transmission. It was tough to get data on that out of China in the beginning. And because it is asymptomatic, it is tough to get data on it now. The public has no understanding of what exponential growth really means, that in 90 days you can go from 1 million, from 1 case to 1 million. We can now go in 60 days from 20 million to 1 billion cases. It's terrifying and very hard for people to understand that if you wait a little bit of time, from 100 cases in 6.5 weeks, you go to 65,000 cases. Time is of the essence. The data we can collect on cases, hospitalizations, and deaths, we have to remember are always 3 to 4 weeks behind the epidemic reality. And that's the data that the public and the press sees, and that makes things very difficult. The other unseen aspect of this that I'm sure you understand as well is if you compare deaths in any week during the epidemic with the year before or the 3 years average before, there are 300,000 excess deaths, more deaths in 2020 than there were in 2019. 1/3 of those appear not to be COVID directly related, and those are people with chronic conditions who can't go or won't go or can't receive the important care that they need. And if one puts that in a global context, we already know from WHO there are 25 million kids not receiving their vaccines, and we can expect epidemics of measles and other childhood diseases, and 130 million more are food insecure, most acutely in Africa because of COVID-19. The collateral damage is clearly as great as the epidemic damage. Obvious to everyone that the key to preparing for an effective response is advanced planning, the rapidity of response, and emergency funds. And the reason I list them this way is what people outside the states and in the states don't understand is after 2006, we had a national pandemic influenza plan. It's a very good plan. It's been updated 4 or 5 times. There was a roundtable exercise in 2017 that the White House ignored after this administration was installed. And the people who were in positions in the White House and the National Security Council left their office or were fired, and the planning response was simply ignored. And that's a tragedy that we haven't come to grips with. And one part of that I mentioned, I had been on a committee at the National Academy in 2001 after 9/11 and anthrax, co-chairing a panel on biosecurity with Josh Lederberg. And one of the things that we learned is that till legislators get around to allocating funds, lots of people are going to get sick and die. And the hardest thing to get through in American Congress is what's called Know Your Money, emergency funds that can be put away in 1 year and used in future years without legislation. Tragically, we had that in the pandemic flu plan, and the government spent it prior to that for reasons no one seems to understand. So the point is, planning is essential. We had it and it was ignored. The other mantra, of course, that you and the press keep hearing about is testing, testing, testing. And I would only point out that testing is not the critical public health intervention, which the public, when they hear only about testing, forgets about. It's isolation of test positive cases, tracing and quarantine of contacts. That's what's required to stop transmission. And that leads to a very exciting scientific transformation, I would hope, in the States on the issue of the sensitivity of testing versus the frequency. The PCR test is very good. As you know, it's the FDA only approved standard test for diagnosis. And it is expensive. It takes time, often 5 days or longer to get results back, which makes it epidemiologically useless. And the issue of the cycle times, it is so sensitive that for much of the time it's measuring dead virus or remnants of virus that tells us nothing about transmissibility and who could go back to work and who not. And so there's a great push now for more rapid tests. Clearly the antibody tests are getting better and cheaper, and I think they will continue to do that over the remainder of this year and perhaps early in next year. They're rapid, they're inexpensive, they're very good for surveillance to tell us where the epidemiology is changing and moving. They probably, as they are done, do not correlate very well with protection. And the reason is the major antigen that those tests pick up is the nucleocapsid antigen, the most abundant antigen in the virus, and that is not related to protection, and people don't often always get that. Second, there are now increasing numbers of new antigen tests. Some of them are over 90% in sensitivity. They are also rapid and inexpensive. And the likelihood, and I am persuaded by the arguments of Michael Minna at our school, is that they will identify by their lack of sensitivity or perfect sensitivity, the people who are most likely to be transmitting, not the ones with dead PCR tests in the nasopharynx, but those with enough to be significant transmitters. And the fact that they can be provided testing in schools and colleges every other day or twice a week or 3 times a week inexpensively gives one a chance to test. If you get 2 or 3 in a row, it's better than 1 PCR test where you don't know what it means. I'm excited about the possibility, which have not yet reached fruition, of rapid, inexpensive CRISPR tests. Chris Happy, as you know, in Nigeria, one of the lead members of the H3 Africa program, has been working with the Broad on a test called Sherlock. I am told there is a publication in press, and that could be inexpensive paper test that could be widely used and has sensitivity almost as great in an hour as the PCR tests. Clearly, the frequency of testing is going to be critical for screening for asymptomatics and symptomatics as well. And that means rapid investments in rapid, inexpensive tests, even if they're not perfect. I am somewhat concerned about the do-it-yourself version of those tests that will look like pregnancy tests. And the reason is there is no way to compel people who test at home to report to the public health system. And if they do not, the public health system will have absolutely no idea who is positive and not, and whether the people who decide that they are positive decide to go back to work and don't isolate. We will have lost control in that context unless there's a great deal more buy-in from the public in understanding of their important role in stopping the epidemic. An obvious point that I would like to make as our country is being overwhelmed with the failure of public health interventions to be employed is if you simply look at the global picture on mortality. If Korea, Singapore, Hong Kong, Japan didn't all get it right at the beginning, but they got it right early on. And they have controlled the epidemic and the mortality tremendously. South Africa has done better for mortality than I can fully understand, and perhaps you could instruct me as to why that you believe is the case. And in the US, we have simply lost control of what could have been done by the simple public health strategies that you know very well. I mentioned the Japan system because in many respects, South Africa has one of the more sophisticated and widespread community health systems. And that was the primary response in Japan. 460 public health care centers led the response in Japan. And once they figured out that they had got it wrong in the beginning, they introduced early testing. Mask wearing has been a tradition in Asia. And I like their version of the 3 C's a lot better than the messaging we give in the States, which is to avoid closed spaces, crowded spaces, and close contact settings. 3 C's makes it very clear to everybody what the risk factors are for transmission in this disease. And the most obvious point here is the outcome of public health interventions is not determined by the scientists, as smart as we may think we are. The leaders and politicians, as we know, particularly from the leadership in my country, have a key role of either motivating or discouraging the public from public health interventions. But the critical value is the K value for heterogeneity in the SEIR epidemiologic model. And that is simply hard to measure, but that's the heterogeneity of the population, how people behave. And it's the behavior of people in this epidemic until we have almost universal vaccination that will determine the outcome. We are lucky with record speed that we have a whole slew of vaccine candidates. I simply show this to indicate 2 things. Several of the vaccines have gotten into phase 3 trials. None of them has completed phase 3 yet. We will probably have at least 2 the RNA vaccines done and the adenovirus done maybe by the end of the year. But there is no surveillance data on long-term adverse effects or real-world effectiveness studies. And I am keen that these vaccines, if the public will take them up, has a real opportunity to make a big difference. Another line in a paper that I wrote that is obvious is the key ingredient in all vaccines is trust. The message is vaccines don't save lives, vaccination does. It doesn't matter what the companies make. If people don't take them or don't get them, it doesn't matter. The most critical parameter in any vaccine is to do no harm. Safety is a top concern, and we have no safety data in phase 3 on any of the vaccine trials. And with even 15,000 persons or 20,000 in the phase 3 trials, we will have only limited amount of information, short-term information, 2 or 3 weeks worth of adverse effects. Thus far, they look remarkably safe, and I hope it stays that way. In our country particularly, I don't know about South Africa and many other countries, the issue of vaccine hesitancy is a big one for childhood vaccines, amplifying misinformation, amplified by disinformation from foreign governments, as well as anti-vaxxers, and the issue of historical exploitation of minority groups that leads them to be suspicious that they will somehow, as a vulnerable, prioritized population, are being experimented on, all of which is going to make the job of getting vaccines to the right number of people very much more difficult, certainly in my country. The role of vaccines, obviously, is to prevent things. And there are 4 things they can prevent. One of them is to prevent infection. That is not a primary endpoint in any of the phase 3 studies that I'm aware of. The measure of the endpoints in the phase 3 studies is prevention of disease, mostly mild disease. And the goal is to prevent severe morbidity and mortality. And those are measured by hospitalization and death. And they are unlikely to be definitive in any of the phase 3 trials that are currently underway. We will have a sense that they do prevent clinical symptoms. And the hope is that there'll be a small number of severe symptoms that are categorized in that group. The key thing from the public health perspective is, do the vaccines prevent transmission of infection? That is going to be very hard to measure. That would require tracking transmission within hospital or nursing homes or household transmission chains, and very few studies, trials are set up to do that. That will be really important. And the reason for emphasizing that is the primate studies with all the adenovaccine vectors have all indicated that while the monkeys were protected against severe disease, and of course monkeys don't get the severe disease of humans, most of the monkeys had viral PCR RNA in the nasopharynx, suggesting that they might be able, in fact, still to transmit while they were themselves protected. And the final outcome that is what is politically important is the societal and economic impact. And we can measure that through unemployment and hunger and homelessness. And they are measures that are public health measures in this context, and we have to be aware of them. I've been involved in the Commonwealth of Massachusetts. The government has very much been involved in the question of who goes first, who gets the first vaccine priorities. Because of the political interventions in the CDC, the director of NIH and the director of CDC requested the National Academy of Science, Engineering, and Medicine to make recommendations. They put together a high-level committee working in very rapid time. And the National Academy, for those who don't know, is interesting. It was created in 1865 by Abraham Lincoln to advise the United States government on matters of science and technology. It is not a government agency. It cannot be manipulated. And so the hope was that they would make serious recommendations on ethical, moral, and practical public health grounds, and they have done so. This is their set of basic summary of their recommendations. And as you will see, the highest risk health workers and the essential high risk workers are given highest priority. And there is a preference all the way through for vulnerable and high risk communities. These are likely not to be the major transmitters within the framework of the epidemic. These are the people most likely probably to die if they get infected. The second tier is school teachers, the homeless, and the incarcerated, then children, workers in essential industries, and everybody else in tier 4. We're struggling with that, and every state is struggling. because how do you define an essential healthcare worker? Is that only people who deal with respiratory and ICU care when vaccines are very limited? Are they the only ones who get it? Who are the other essential workers in society? And on the issue of people with comorbidities, 47% of Americans have at least one known comorbidity. How do you verify that once the vaccines are limited and someone says, I have diabetes or hypertension? That's going to be a nightmare. And how do we balance the social concerns like opening schools and getting vaccines to minority populations in high density housing complexes who would not fit in the top #1 priority group? And in the US, for example, healthcare workers that deal with these patients have very low incidences of COVID infection, and most of it in hospitals is brought in from the community rather than taken infections within the hospitals. So these are challenges. The second level of challenges is the question of whether the first vaccine candidates are likely to be the best, and the best in various different circumstances like South Africa. All of them that are being tested, with the exception of the J&J Adeno 26, at the moment appear to be 2-shot vaccines. As you know better than I, getting people back 21 or 28 days later is going to be a real problem, particularly in rural areas. The Pfizer vaccine requires -80°C, which is not on, in my view, for vast amounts of the world. They're not very stable. They have to be kept in dry ice. They can stay out for a few hours, which means you have to line up 1,000 people to thaw one batch. If you have only 500 people, you end up throwing away half of the vaccine. And the delivery problems of travel, of flying vaccines around the world in a supply chain with -80 or -20 is going to be very difficult. We don't know, and we probably won't know in any serious way, whether they're productive in older people, and we have no idea and will have no idea how long protection endures. It is very encouraging that the Pfizer vaccine 7 days after the booster shot was 90% protective in their phase 3 trial. As a very old long-term immunologist, I can tell you no vaccine has ever failed in a mouse or in a rabbit that was tested and challenged 3 weeks after the booster shot. So take that with a grain of salt. But I'm not surprised that it was good, because these platforms have been through a lot of study in animals and in phase 1 and 2 studies. And I would hope they would be in the over 75 and up to 90% level, even for some period of time. The bad scenarios obviously are they protect against disease and not transmission. That makes the job of public health very difficult. Or they protect young, healthy people and don't protect the people we are targeted in our top categories from dying. And what the question then is, how do we get to, if there is such a thing as herd immunity in this infectious disease? I want to share an anecdote. I would criticize any student who did what I'm about to do. Anecdotal evidence is not real evidence, but I find this a completely intriguing and appealing example that you may not have seen. There's a fishing boat that launched from Seattle, Washington, and they bled people before they went out on the boat for 18 days. None of the people had PCR COVID infection when the boat left. And one of the people got quite sick on the boat and they had to bring it back to shore. And then they looked at what happened in the members of the boat after they returned relative to what they had before. So the answer was there were only 3 people on that whole boat of 120 people that had neutralizing antibodies before they left. The attack rate was over 85% of the people on that boat got COVID infection in 18 days. Only 3 people did not get infected. And those 3 people were the people who had neutralizing antibodies. There were 14 people who had antibodies by the PCR test that measures the nucleocapsid antigen antibody reaction, and they did not show protection. That gives me some hope that since all the vaccines are targeted to the S protein and believe that if you can neutralize S protein binding to ACE2, you will get neutralization. This is a real world example where, to a large extent, that assumption may be working for us and may be very encouraging. And in the 2 of the 3, the titers were only 1 to 150, which are lower than many people with convalescent serum would experience, at least short term, after convalescing. So I take this as a very hopeful sign for vaccines. Let me end with a common maxim that most people would agree to, that an infectious disease anywhere is a threat everywhere. 90% of the world's people remain susceptible to SARS. 92 countries clearly will not have the resources to purchase new COVID vaccines. You are well aware of the COVAX program in South Africa, which is a terrific idea from the Norwegians and CEPI, the Wellcome Trust Foundation. This is really encouraging. 188 countries have signed on, including most recently China. Regrettably, my country has not joined this effort, or the World Health Organization. And on January 20th, if Biden is installed as our next president, he has promised to do that again. That gives me hope as well. And I will end my talk with a question that I don't understand, is why does South Africa not have a domestic vaccine production capability? And with that, I will end on my favorite of all of these maxims from Leo Szilard, a nucleophysicist who I knew when I was a graduate student when he was in New York and stayed at the Rockefeller University. Having derived the formulas that created the atom bomb, he was asked whether he was an optimist. And his answer was, an optimist is someone who believes the future is uncertain. In that sense, I am an optimist. Thanks so much for allowing me to share these completely obvious thoughts.
Thank you very much, Barry, for a fantastic overview, a real global bird's eye view on the epidemic and the response to the epidemic, and really a lot to take us on to the discussion. So I'm going to move on to introducing the panel and then ask them to make 1 or 2 comments and pose 1 or 2 questions. So the panel members are Hassan Mohammed. Hassan is a public health specialist at the Provincial Department of Health and also affiliated with Stellenbosch University. Val Mizrahi, who's the director of the Institute of Infectious Diseases and Molecular Medicine at UCT, and Mark Mendelsohn, the head of infectious diseases and HIV medicine at UCT. So Hassan, to bring you in, any points or questions that you wanted to raise?
Thanks, Graham, and thanks very much for the privilege to be on this panel. And thank you, Professor Bloom, for your fascinating, interesting, brilliant presentation. It was very insightful and still a lot for us to learn. Thank you particularly for the slides on vaccination. I mean, I think as South Africans, we haven't quite got there in starting to plan the details around how a vaccination program would work in South Africa, but as these trials come to fruition, certainly it's something that we need to be prepared for, and we need to look at how we would implement it here. I'll provide perhaps just some comments and questions, from our experience. I've been involved in coordinating contact tracing within the province, together with colleagues like Mary-Ann Davies and others, trying to respond to the COVID outbreak or epidemic as we've had it here. I think what we've learned has been an enormous, I suppose, way of trying to respond to something extremely challenging and stressful to any health system. I think some of the biggest challenges have been around testing and contact tracing and the feasibility and workability of such initiatives. Again, our approach as we move forward is to focus much more on non-pharmaceutical interventions and promoting behavior change within the general public. As you say, there's a lot that we don't know. So certainly agree with you. We don't know most of the cases that are spreading disease out there in the community. So for that very reason, general population measures are what we feel should be prioritized in terms of our response to the epidemic and to limit further spread. Contact tracing is limited. The proposal by WHO to test has been very difficult for us in terms of our resources. And we really only see the value of testing if we have capacity to do mass testing as they are able to do perhaps in South Korea or China. We certainly are not at that level, which makes testing and contact tracing contribute in a very limited way to containment. So our approach is to focus on high-risk groups and contained settings like old age homes, schools, workplaces where an outbreak response and limitation of transmission within these confined or high-risk contexts is feasible, rather than trying to achieve spread within a general community setting. So we've had to prioritize which direction we go in, but certainly the newly developed tests that you mentioned, antigen tests or antibody tests, will be helpful, maybe antigen tests particularly in terms of our outbreak response situation. So if those provide us with the opportunity to do more widespread testing, this will improve our ability to test and to do then contact tracing and limit transmission through that mechanism. So these are just some of the challenges. In terms of ability to respond, I mean, I think we have a challenge now of so-called COVID fatigue, where the general population are not happy with continuing to be restricted, are not willing, and this in the practical reality is happening to us, not willing to adhere to isolation and quarantine measures. So we are facing an uphill battle to achieve those kinds of public health measures to try and achieve containment. And we are particularly in a difficult situation facing our holiday season, which is coming up over the December-January period. So our work is cut out for us. But nevertheless, we are strengthening our communication strategies and trying to build trust. And I like the fact that you've mentioned that as an important issue, trying to build trust, not just around vaccinations, but around these public health prevention measures to try and achieve some kind of containment. So I'm going to stop there and just say those are just general comments in response to the presentation. Thanks very much for your presentation and then for the opportunity to comment on it. Thank you.
Thanks very much, Hassan. Barry, I should mention that Hassan has played a leadership role in the province in terms of our public health response and really has shared some of the very practical challenges that we've faced. I don't know if you have any responses.
I'm very appreciative of that, and your challenges are very similar to our challenges. I wish you great success. People are fatigued, and dealing with that is going to be a very big public health challenge.
Right. So then to move on to Val Mizrahi, Val, to bring you in on the discussion. Yeah.
Thank you, Barry. Firstly, it's such a huge privilege. It's wonderful to see you, and I'm so delighted that you're here. Barry, like you, I am fundamentally optimistic. I believe in the principle But I'm also want to push you on the question of what you feel the lessons are for other infectious diseases. So if you look back on the last 11 months, a question I have is how can we capitalize on this moment to infuse a much greater sense of urgency and agency as we think about addressing other challenges in infectious diseases, which TB and AMR loom large. Your thoughts about that? And then I have another question after that, time permitting.
Among the collateral damage is the almost total shutdown or a major shutdown in TB control worldwide. And I used to show, as you do, Valerie, a slide showing the largest cause of death from any infectious disease is tuberculosis. That is no longer the case. The case is now, number one is COVID, and that has taken center stage. In a curious way, it's a lot easier to deal with an acute epidemic than it is with a chronic epidemic. And I'm not sure it is obvious what lessons to take. If the vaccines work against COVID, maybe, just maybe, that will be a stimulus to repeat one of the 2 trials in South Africa that gave us some hope that TB vaccines might even be 50% protective, that are really not interpretable now, since we don't really know whether the M72 works in people who have not been prior exposed, or whether BCG repeat does anything in any other part of the world than in South Africa when it's failed in 6 or 8 other studies. So I'm not sure we can take a lot of messages from the practical implications other than if vaccines work here, we have to double down on vaccines. The real message in all of this that's really tough in public health, and it's so obvious, is you need to prepare for epidemics. They come. Josh Lederberg in 1952 predicted pandemics of influenza. We know they will change antigens and they will come. And politicians do not deal with epidemics until they're here, and that's already too late. And I don't know how to change that. And the one positive thing that I would really argue if you can get done is get emergency public health funds put away in the national budget. So bad things happen, there are things to start up with testing quickly and interventions quickly before the government has to move the wheels of state to get new monies to throw at whatever new infectious disease epidemic comes down the line. And that was as true with HIV as it is for COVID. And so we haven't learned that lesson. And it's all preparation, rapidity of response, and having immediate funds to be able to prepare.
Thank you.
And Val, your second question?
Yeah. I've got to squeeze in another. Barry, as you look back in the last few months, what has inspired you the most?
I'm sorry, I can't hear your question. Could you repeat it?
What has been your biggest disappointment and what has inspired you the most?
I told you I was going to ask you a tough question.
I guess my biggest disappointment, obviously, is twofold. That the government didn't listen to the scientists in January. When everybody that I know of, and certainly at my school, when the first modelers predicted how many people were going to get sick unless people intervened with standard 3C public health interventions, nobody paid attention in the wheels of power and government, and as if epidemics and R0s were debatable. Other governments responded in a very different way. So that's been the long-term disappointment. The short-term disappointment is my reaction to the election last week was that the population itself, the public, has basically given up on investing in controlling the epidemic. And that recurs back to Hassan's comment of COVID fatigue. The fact that the #1 health problem in the States turned out not to be the #1 problem that determined how people voted in the election, I find quite discouraging. What gets me really excited is the science is unbelievable. That a Sherlock test with paper strips and CRISPR in 60 minutes could give you 98% specificity for less than $5 a test. I have slides that I won't show. There are 3 papers out in Science this week that I find mind-boggling. As you know, Regeneron and Lilly have gotten approval for monoclonal antibodies with high affinity that target the receptor binding domain of SARS-CoV-2. So that's terrific, except you can't make a lot of monoclonal antibodies. The capacity for production is really maybe 10 million doses, and 8 grams of the stuff went into the President of the United States. 8 grams of immunoglobulin rather. That's hopeless from a public health point of view. So there are 3 papers in the current issue of Science that really jazz me up, and the references are in the slide set if you get a chance to look at them. 2 of them produced nanobodies, which are variable regions of llama or camelid monoclonal antibodies that are very small and have the capacity, in contrast to the parent monoclonal antibodies, to be made either in bacteria or in yeast by fermentation. Any brewery can make tens of millions of gallons of these nanobodies that have the ability to bind and block COVID-2 and its interaction with the receptor. And the price that they would be produced at is ridiculously small. Second, they are not vaccines. They probably don't protect people who are sick as a therapeutic, but they have the great advantage of being almost totally heat stable. They don't require refrigeration, and they can sprayed in the nose. And there's one of the studies in hamsters that shows that if it's sprayed in the nose, the hamsters don't get sick, or The third paper is a synthetic compound that binds to the receptor binding domain on the virus with very high affinity. It's a chemical compound. It probably can produce not as cheaply as the nanobodies, but again, if it's chemistry, it can be made, and if it can be made, it can be distributed. And then the challenge would be, if the vaccines work well, there's probably not a need for this. But till that's the case, and that may be for at least a year, we have the potential for cheap, inexpensive treatments in asymptomatics, in people with preconditions that have the capacity to protect against infection, which we don't know about in vaccines. And the science really gets me really excited and keeps me awake at night. And it will only get better.
Thank you.
Thanks, Val. So next to bring in Mark Mendelson is the head of infectious diseases at UCT and has also been the chair of the Ministerial Advisory Committee nationally on the clinical management of COVID-19. So Mark, to bring you in on the discussion.
Thanks very much, Graham, and Professor Bloom, thanks very much for a really thought-provoking talk. What often seems obvious to you is, enlightens others in ways that perhaps they haven't thought about. And I'm going to push you a bit. I mean, one of the things about going third, of course, is that the 2 questioners before didn't steal all your ideas. But I mean, I want to put this issue of the testing, isolation, and quarantine to you in a different way. I mean, you've highlighted, and Hassan has highlighted the problems of this. You spent much of your life advising WHO. I mean, if you were to advise WHO how to message and how to respond for countries who really cannot isolate and quarantine in the same way as perhaps South Africa, exemplifies. We had to move to really protecting our health systems. We were unable to do it, and as an upper middle income country, we're fairly well off. Most countries in Africa and other areas in the world just can't do it. Yet WHO's mantra still continues to be this. How would you go about messaging? And the other two issues, just briefly, you mentioned pandemic preparedness, and we're all famously good at trying to get up to speed too late, and then everybody going to sleep and forgetting about pandemic preparedness. What would you advise going forward? And lastly, you mentioned this revolution in publication, which has been amazing, but what do you see the downsides of this are and the dangers of it going forward? Thanks very much.
Very, very hard, very, very good questions. The answer to the first question is really very difficult. I've had this come up in the context of India, and it recurs. To answer it better, I would have to understand something that I really don't, which is why the mortality rates in South Africa, in other countries in Africa, and in India are so much lower, apparently, than they are in the States. The standard answer is for this pandemic, 90% of mortality in the States is people over 65. And if you look at the age distribution in Africa and in India, for example, the distribution of ages is far younger. And so the obvious conclusion is ideally one would like to have identification, particularly with cheap antigen tests if they become available, and have people isolate. The magic ingredient for isolation, both in my country and in developing countries, we don't talk about because no one wants to pay for, which is the fourth component of isolation, testing, isolation, quarantine. It's called support. And one of the striking things in Wuhan, in China, that no other country has done quite as well, has been the support system. When China said everybody has to stay home, well, a lot of people can't make a living or can't eat or provide food for their families. And thousands of volunteers were able to distribute food in an organized way in Wuhan with government subsidized foods. Even in India, there was a massive attempt to subsidize foods after the 4-hour notice of lockdown. That was a tragedy in a sense, where the migrant workers were locked up and they couldn't migrate, or they couldn't until they just decided they couldn't survive otherwise. But when they were locked up, the government did its best to provide food kitchens for the people. So the only way for lockdown to work is if there is support for those people, which is dedicated to be able to keep them locked up within the households until the time, which may only be 5 days or may only be less than 10 days, where they become or are able to be transmitters. And the rapid tests may be the key way of knowing how quickly we can let people out from that circumstance. The second question was, how do we prepare for future pandemics? How do we prepare? And I go back to the fact that WHO is in an impossible situation. It is absolutely impossible. It has no budget to execute anything. It can get the best advice in the world, but it is not an international organization. It's an intergovernmental organization. Think of a corporation with 194 members of the board of directors each from a different country, who shows up 2 weeks a year to set policy, that it can do anything in the level of setting ethical, moral, and scientific guidelines is remarkable. But all healthcare is local, and the best that WHO can do is advise governments on what in their context they should do. So I think we have to be grateful for what WHO can do. My heart bleeds for the Director General, who will take abuse for whatever he does or does not do. But the responsibility in the charter of the World Health Organization, that people don't appreciate how revolutionary it was in 1948, is governments have the responsibility for the health of their people. And that is obvious to us now, but before 1948, government had no responsibility. It was the family or the clan that had responsibility for the health of the people. So I would take WHO and say, I am grateful for what they do, but the action has to be with the government of South Africa, the government of the United States, and the government of India, with the resources that are available to do the best they can. And the third question was, I'm sorry, Mark, I forget.
That's fine. It was about this issue in the revolution of publication and whether there are downsides or concerns you might have, particularly the uptake of science without peer review.
Yeah, you and I and everybody on this call read some of that stuff. Luckily, much of it is case reports, so it doesn't necessarily, if they're not totally accurate or scientific, they neither add or much or subtract much. I guess my sense is, in the face of a pandemic, whatever is scientifically put it this way, I'm not the biggest fan, as you can tell from my anecdotal case, in p-values. I am also, in many cases, but not the case of vaccines, I'm not a big fan, or the biggest fan, for randomized controlled trials. And the reason is, for anybody who worked for a long time in developing countries, there are just lots of things in developing countries that you simply can't control for. And I'm a big fan of quasi-experimental studies, regression discontinuity experiments for new interventions. For example, in the States, to test a vaccine, it is absolutely essential that you have phase 3 randomized controlled trials, ideally not against saline, but against another vaccine, so everybody doesn't know what they got. When those vaccines are introduced in South Africa, you have the opportunity, as my former teaching partner, Till Barnickhausen, who is now back in Germany, but working in Cape Town, has done. A regression discontinuity said that what happened to the incomes of people, what happened to hospitalization, what happened to life expectancy of the people of KwaZulu-Natal before and after antiretroviral therapy was put in. Really cheap experiments to do, just collecting data that was available and making new available data. And they knew very quickly that life expectancy was extended in KwaZulu-Natal by 11.2 years within 2 years after ART was put in. Hospitalizations went down 45%, and 75% of people who were thought to be wards of the state and a drain on the treasury forever went back to work, obviously mostly in the informal sector. And those are things that can be done to measure effectiveness once the first set of randomized controlled trials is done. So I truly believe we need rigorous science at a certain point, and we need to get data in the real world where it is not possible. When you exclude everybody over 60, You exclude everybody under 55. You exclude everybody that has a precondition, and you call it a randomized trial that's going to tell you how a drug is going to work. I would be more open personally to linking those where necessary with quasi-experimental studies. And that may be heresy for a dean of a school of public health. I'm not immune to criticism.
Thank you.
Thanks, Mark. So Barry, can I just ask one question before we just look at the chat function? You mentioned the collateral damage that's been done in terms of child health and people living with chronic diseases. Do you think there's anything that could have been done differently, really on a global level, in terms of our response to the pandemic, that would have prevented some of that collateral damage, and particularly going forward, some lessons that we've learned that could allow us to still continue with those services despite our response to the pandemic?
Wonderful question. And as I mentioned, I'm on a committee in the Commonwealth of Massachusetts that is to decide and recommend to the state how to distribute limited vaccines when they come available. And we do have the advantage of a lot of academic institutions that do have minus 80-degree capacity in many places, and much easier time than you will have and others for the initial specialized vaccines. I guess what I would have to say is we will get guidelines from the CDC, ultimately based on the National Academy, based on the ethics and the vulnerable populations and the historical as well as current disparities in health. I hope they are more flexible in the sense that in Boston, in Massachusetts, very few physicians, even in hospitals, are either getting or transmitting coronavirus. They are not the highest risk group at risk. It is essential that doctors get vaccinated, because if the medical community doesn't accept vaccines, I can tell you a vast amount of the public is not going to accept vaccines. So there is a tremendous sort of moral suasion and power of showing the medical community is all in for vaccines, even if they are not the most vulnerable group with availability of protective equipment. The big debate here, and I think in many places in the States, has to do with schools. So what do we know about kids? We know that in the States, of all the cases that have been characterized, kids represent 11% of cases of infection. They have a very low 0.015% mortality rate, very low mortality rate. Having told you that, more kids have died from COVID in my country than have died from influenza, which is a known killer of children, albeit we have influenza vaccines. The damage done to kids, keeping them out of in-person learning, is enormous. And how does one balance that with the National Academy of report of who's going to live and who's going to die? And my feeling would be as feasibly as possible to get kids back in school. And the only way I know how to do that is to prioritize school teachers from the second category or the second phase of immunization, and say they're every bit as essential in our society as physicians, and make sure, and a big chunk, 25% of teachers in the US are over 50 years of age, and many are over 60, and they are vulnerable. And that would have a huge impact, I believe, on the long-term collateral damage if we could maintain the educational system. And I would urge that and other essential workers to be given flexibility within the vaccine allocation to be prioritized. That's the best I can answer.
Great, thanks. I'm just going to go to Wendy or Mark to see if there's anything that they want to raise in terms of questions from the chat.
So I think, Graham, Mary Ann Davies can comment on the mortality of South Africa, which I think is an important question to address. Mary Ann?
Yes. Thanks, Wendy. So our reported mortality and what appears on our world in data is probably only a fraction of our true COVID deaths. We have also been monitoring excess deaths in South Africa, and the reported COVID deaths account for only about 40% of the excess deaths that we've seen in the country, with huge variability between provinces. So in the Western Cape, we can account for about 90% of those excess deaths as being due to COVID, but in other provinces, of the excess deaths, only about 10 or 15% in some provinces are actually reported COVID deaths. But the pattern of excess deaths matches the COVID surge pretty closely. And in fact, in the Eastern Cape, which is a province that's currently experiencing an increase in cases, we are also seeing now an increase in excess deaths. I didn't show the excess deaths this week. So I think if we look at our excess mortality nationally, and if we say, let's say 80 or 90% of those excess deaths are actually COVID deaths, that puts us with a mortality rate of around 700 or 800 per million. So we certainly haven't escaped. And I don't think we're anything of a miracle. I can't comment on other countries. And when we look, for example, within the Cape Town Metro, in some of our areas that have been worst hit, and of course it's not fair to compare that with the whole country, but some of our areas have had mortality of 1,000 per million in our densely populated communities. And once you consider that we have such a young population and look at age standardized mortality rates, that even goes higher. So Khayelitsha, our probably our poorest area in Cape Town, the age standardized mortality rate there is about 1,600 per million. So I don't think we've achieved anything remarkable in terms of mortality. Others may want to comment. Andrew Bull is also on the call, but yeah.
Wendy, any other questions?
So Graham, just some comments from Linda Gale Becker. Basically, the announcement that Aspen generic tech transfer from J&J for vaccine work. So potentially there is a transfer of knowledge there. The other question, also from Linda Gale Becker, was that Eli Lilly will make 1 million Rogaduran monoclonal cocktail doses available, and wants to know where will those be directed, the Eli Lilly monoclonal cocktail doses? Is that going to be generally available or only targeted? So maybe Barry, you could answer that.
Graham, I'm having trouble with echo. Could you repeat the questions, please?
Sure. So Linda Gale Becker's question was, she understands that Eli Lilly will make 1 million doses of the monoclonal cocktail available, and where will those be directed?
If I could ask to show one more slide, if you could allow me to show my screen.
Are you able to do that, Wendy?
Please go ahead.
Yeah.
Thanks, Mark.
This is an interesting picture from Nature in indicating the potential availability that was committed to or predicted by each companies and the vaccines as of August. They're all probably a little behind schedule, but we're talking about billions of doses being available by the end of 2021. And on the right-hand side, these are commitments, so that for the UK, commitments were made for the government to buy these vaccines. In the US, there is a commitment to buy now more than 2 doses 2 billion doses per capita. So if one looks at the new vaccines, those that are not yet in phase 3, a couple things that I would point out. One of the things that is interesting to me is the subunit vaccines, which can be produced quickly and in large amounts. From the preliminary data of the Novavax vaccine that was originally supported by CEPI, if they can do reproducible high-scale production, they've produced higher titers than anybody else. The half-life of antibodies is about 21 days. So the higher the titer of neutralizing antibodies, inevitably the longer the protection will be. So I'm pretty optimistic about much of that. And then not here is Merck. And the interesting thing about Merck is that they are just in phase 1 at this point. They've made no commitments. Nobody has bought their vaccines, but their target is one-shot vaccines. Their vaccines, they're using either recombinant VSV or recombinant measles, both of which are used have been used in Africa. The VSV is what was used to control Ebola, as you know, in the Central African Republic. And measles is one of the most widely used and effective vaccines in the world. So if either of those works out, they would fit in easily to the existing chain. So I guess what I'm saying is there will be a lot of pain short term in not getting access to the initial vaccines. And I think South Africa and every lower middle income country should think very hard about what the contract commitments they're able to make to get vaccines that practically make the most difference to be the most effective in their own context.
Great, thanks, Barry. So I think we're over time, and we've really had a highly informative discussion. Your presentation was extremely thought-provoking, a great discussion, and I think you leave us on an optimistic note, but with also some challenges in terms of what South Africa needs to do to position itself with respect to vaccine access. So thanks very much for your inputs this afternoon, the time, and really leading a fantastic discussion.
Thanks to you and to everybody who was kind enough to stay on.
And thanks to Marianne and to the 3 panel members as well. So just to say, we will have our next webinar in 2 weeks' time, and then we will have another 2 after that before the end of the year to wrap up this COVID-19 webinar series. So thanks very much, Barry, once again.
All best wishes.